So next is post-op complications after bariatric surgery. It's V3. So basic signs, potential sites of internal herniations after laparoscopic removal and gastric bypass. It's a mesocolic defect if fluidocolic use is used. Jejunal mesenteric defect at the site of jejunojejunectomy. And Peterson space between the alimentary limb and the transverse colon. A 33-year-old female with BMI of 52, background of OSA, type 2 diabetes mellitus, hypercholesterolemia, and previous DVTs, undergoes laparoscopic removal gastric bypass. Your registrar rings you in the early morning because the patient has vague epigastric pain and feels nauseated. On examination, she had a pulse of 130 and is in pain. Abdomen is soft. What would you tell your registrar, and what's your so I will tell the patient, my registrar, give analgesia, fluids in patient in the early postoperative period following gastric bypass surgery who is in pain. Tachycardic from surgery is presumed to have an anastomotic leak until proven otherwise. The most common site for anastomotic leak is the gastric pouch enterostomy, and this typically presents within the first 24 hours. What would be the investigation of choice? If immediately available, CT scan. If patient is too much to go for the CT scan, then it will be re-laparoscopy to confirm or exclude leak. If a leak is found, how would you manage the patients? So drainage and nutrition are the treatment goals. A leak can be primarily sutured or sutured over a T-tube, forming a controlled fistula. If primary closure is not possible, finally I would perform a thorough washout of the abdominal cavity with warm saline and place a drain. Post-op patient should be managed in at DU. Nutritional support, analgesia. What post-operative chest complications are common among these patients? Include atelectasis, pneumonia, as well as PE. All these patients are high risk and should receive thromboprophylaxis. DVTP is the commonest cause of mortality after bariatric surgery. What other early and late complications can occur after a laparoscopic removal gastric bypass? Bleeding from the staple lines and anastomosis can occur as an early complication up to 4%. It will present as a melena and typically settle with non-operative measures. Late complication includes stricture at the pouch enterostomy up to 5%. Managed with endoscopic dilatation, vitamin and mineral deficiencies due to unavailability of duodenum and proximal jejunum for absorption and internal hernias. There are several potential sites of internal hernias following laparoscopic removal gastric bypass: Peterson defect, mesocolic defect, jejunojejunectomy defect. The rate of internal hernia and potential bowel ischemia is at least 2% over the initial 1 to 2 years. It is important to be aware of this late complication as the potential spaces following bypass surgery become larger as weight loss progress. A 41-year-old female received a lap adjustable gastric band 12 months ago. Her BMI is 29 with pre-op BMI 42. She had her band adjusted last week since she had been getting progressive dysphagia and has not been able to swallow round saliva in the last 10 hours. Your registrar rings late at night of her device. What would you tell your registrar, and what is the main thing? This patient needs an urgent deflation of her band, which should not wait overnight. This should be done ideally by the non-coring needle such as the Huber needle, but if it's not available, a standard needle can be used. Full aspiration should lead to the immediate resolution of symptom. If not, band slippage should be suspected and further investigation is urgently needed. The management of a slippage is immediate band deflection followed by barium swallow. If symptoms persist following deflation, then the urgent laparoscopy and band removal are needed as there is a risk of gastric ischemia. This can be done by general surgeon. At outpatient follow-up of 29-year-old male who had a lap gastric band, there is noted to be a pain, discharge, and erythema. What the site of inflation port? What is the significance of this, and how should it be managed? These signs represent a port site infection, which is disaster. The underlying cause and management is dependent on the length of the time since surgery. A port site infection occurring within the feces is likely the result of skin bacteria contamination. However, the infection can track down the tubing and cause a band infection, which can lead to band erosion. The pragmatic approach is to prescribe appropriate antibiotics, but also rearrange laparoscopy to cut the band tubing and remove the infected port. A new port can be connected at a later date. If port site infection occurs months after band erosion, it is more likely to represent primary band erosion. This is often associated with loss of band and restriction. I would perform an upper GI endoscopy to confirm the diagnosis before removing the band completely at laparoscopy. If the patient wished for further bariatric surgery, I would wait for 6 months before converting to a gastric bypass.